Thank you. Good afternoon. This is a picture of Richard Nixon signing the National Cancer Act in December 1971, almost 45 years ago. This is a good time to actually think about what's going on in cancer and what we're doing. I'm going to start out by telling you the punchline. American Cancer Society epidemiologists estimate that this year 596,000 Americans will die from cancer. If all Americans had the risk of death or death rate of college-educated Americans, 148,000 of those deaths would not happen. We have a huge problem with access to care and access to usage of care, to include preventive care. Now, when Richard Nixon signed this bill, Ted Kennedy, by the way, called it the nation declaring war on cancer. Another senator actually predicted we'd cure cancer by the bicentennial in 1976. That was just a little bit optimistic. What the bill actually did was it actually gave command and control of the National Cancer Program to the director of the National Cancer Institute. The bill established a number of things that actually were going to accelerate discovery, accelerate getting treatment to patients. Let's talk a little about the history of cancer. This papyrus from 2000 BC is the first recorded mention of cancer that is known. Literally, this scribe, and I don't think any of us can translate it directly, talks about cancer as a disease. And cancer was a huge problem throughout history. Many of us don't realize exactly how our definitions of cancer today came about. And they actually revolve around this gentleman, Rudolf Virchow. He was a pathologist at the University of Berlin, and he and his colleagues worked over a period of about a decade in the 1840s and 1850s. And they are the people who actually first described cancer as we know it today. I think it's important that we all realize that we're still working off of a mid-19th century definition of cancer, and we are about to move into a 21st century definition of cancer. You see, Virchow and his colleagues did a series of autopsies, and they were the first people to actually do fine cutting of tissue, mounting them on slides. They were the first people to stain them, and they were the first people to look at cancer under a microscope. And since they didn't have photography, they drew pictures of things like this. This is an adenocarcinoma of the breast. That's what cancer looks like. When a pathologist gets a biopsy and processes it on a glass slide and looks at it under a microscope, this is what he or she sees. And this is when they say, this is cancer. Now, Virchow also was the first person to realize that cancer was uncontrolled cell growth. Here you can see these beautiful pictures in the top left. That's prophase, bottom left is metaphase, top right is anaphase, bottom right is telophase. This is the process of mitosis. By the way, I stayed up all night practicing saying that. When I cut my hand, if I cut skin, those cells start going through the process of mitosis. We call that healing, controlled cell growth. Cancer is the same thing. One cell becomes two cells become four cells become 8, but it's uncontrolled cell growth. And that's what Virchow and his colleagues first told us. They were the people who figured out that cancer starts out in an organ as uncontrolled cell growth, and cancer actually grows and then spreads and kills. This is a picture of a breast cancer that is spread to a woman's skeleton. All those dark marks there, that is metastatic breast cancer to the skeleton. Now, what's happened over the last 160 years is, after Virchow and his colleagues defined what cancer is with that biopsy I showed you, we've had development of mammography in the 1950s. Actually, X-ray in the 1890s, mammography in the 1950s. 1960s, we got ultrasound. We got CT scanning, computerized tomography, or CAT scanning in the 1970s, MRI in the 1980s. And today we even have some stereotactic biopsy equipment that was patented this century. And so at a hospital near here today, some woman is going to get mammography and some of these other tests, and a pea-sized lesion is going to be found in her breast. And with the stereotactic biopsy equipment, we're going to get a needle into that pea-sized lesion, send a piece of that lesion to a pathologist, and he or she will mount it on a glass slide, stain it just like Virchow did, use a microscope that now has an electric light bulb as a light source, and they're going to look at it, and they're going to see that adenocarcinoma thing, and they're going to say, this looks just like what Virchow said killed that woman in 1850. This is breast cancer. Now, the problem, of course, is epidemiologists will tell you, and this is part of the reason why screening is a question mark in breast and prostate and other cancers. For breast cancer, 20 to 30% of these small localized breast cancers are not genetically programmed to grow, spread, and kill. In prostate cancer, it's 50 to 60%. When we do lung cancer screening of the early lung cancers, it's about 20 to 25%. They are not genomically programmed to grow, spread, and kill. They look like something that kills someone in the 1850s. They look like something that kills people today. In many respects, the analogy here is one that I'm very used to using, is racial profiling. This is racial profiling goes to pathology. It looks like something that kills someone, therefore we assume it's killing. Overdiagnosis is the word that we use to describe this problem. And it is one of the reasons why screening is a question mark for breast cancer and prostate cancer. It's one of the reasons why we know that we are over-treating some of these diseases. We actually cure some people of cancer who don't need to be cured. And that's hard for many people, including doctors, to actually adjust to the concept that there's such a thing as a good cancer or a bad cancer. Now, we talked about the National Cancer Act, or the war on cancer. Many people ask me, because I'm the chief medical officer of the American Cancer Society, what has it gotten us? Well, it's gotten us an understanding that there are good cancers and bad cancers. It's gotten us some molecular tests that are actually helping us figure out which are the good cancers and which are the bad cancers. And in the next 10 to 15 years in breast cancer, we're going to say, Mrs. Smith, you have breast cancer, but it's one of the good kind. Therefore, we're going to watch you and not treat you. Or Mrs. Jones, you have breast cancer, and it's one of the bad kind. Already, we're using these genomic tests to say, you have a less aggressive breast cancer, so we're going to treat you, but less aggressively. Or you have a more aggressive breast cancer, and we're going to treat you aggressively. We got that out of the National Cancer Act. We got that out of all the money that went into research. We also got a better understanding of what's going on in terms of the epidemiology of cancer. Here you can see, I'm an epidemiologist, I have to show one number slide, I'm sorry. In 1900, for every 100,000 Americans, 64 died of cancer. In 1991, for every 100,000 Americans, 215 died from cancer. That was the rise in cancer deaths over the last century. Peaked in 1991, and then it started dropping, such that by 2013, the last year we have data, we have a 24% decline in death rate from cancer. That means that your average American who's 50 years old today, their risk of dying from cancer in their lifetime is 3/4 of what it was for the average person of the same age in 1991. That is some progress. In colon cancer, we've had a 40% decline in risk of death from colon cancer. That's due to screening that actually works. That's due to improvements in treatment. In breast cancer, we've had a 35% decline nationally. Now, I say nationally because of the following. I could show you this in colon cancer as well. These 10 states, or 12 states, have had less than a 10% decrease in cancer mortality. I started as an epidemiologist talking about black-white disparities, and now I talk about Arkansas versus Massachusetts disparities. We have a problem in our healthcare system. We're not giving good preventative care homogenously across the country. We're not giving good treatment homogenously around the country. We threw these 12 states out of the United States. The death rate from breast cancer, instead of 35% over the last 25 years, would be close to 45%. We have a huge problem in delivering good care. And at the same time, Nixon's war on cancer has given us tremendous understanding of what's going on inside the cell. This cartoon shows us a number of molecular pathways below the cell wall going across that slide, and shows us a number of drugs in the squares above the cell wall. And these are drugs that can interfere with various molecular pathways. They signal transduction inhibitors and other things that help us to treat cancer and help us to treat cancer well. We've learned a great deal about what goes on inside the cancer cell and how we can manipulate it. And we're getting better and better at doing it. We also recently learned a great deal about the immune system. You know, it was over 100 years ago that we had some patients who had head and neck cancer who got strep infections in their tumors, and the tumors actually started shrinking, and that's what made us think the immune system might be good at tackling cancer. And we've developed a number of drugs recently that do some very interesting things. They don't spur the immune system on. They block the tumor's ability to say, I belong here. You see, your kidneys have an ability to tell your white cells that it belongs by putting up this sign that simply says, I am a friend, do not attack me. People who have lupus, their kidneys are unable to put that up as well. Well, tumors, be it lung cancer, melanoma, actually have the same system. They can say, I am a friend, do not attack me. We've actually developed drugs that interfere with that signaling system. And therefore, the T cells of one's immune system starts attacking the cancer. This is the beauty of immunotherapy. And it is working very well for certain specific cancers. So we've got molecularly targeted therapy, we've got immunotherapy, we've got a lot of good things that have come out of Nixon's war on cancer or the National Cancer Act. Now here comes Vice President Biden and President Obama, who have issued a new challenge. They've decided to have a moonshot in cancer. This too, like in 1971, is an effort to bring more command and control to cancer. We need people who are actually working this war in an organized system, who can actually say we need more of this and less of that. Now, my this and that are things that have to do with molecular biology. We need less studies in DNA repair. We need more studies in signal transduction or vice versa, that sort of thing. But we need someone who's actually controlling. Now, the moonshot is a great thing for developing and speeding up cancer science, finding new drugs, finding new treatments, learning more about cancer. It's a wonderful thing. But we've got to focus again on getting these things to the people. No drug has ever worked if it wasn't administered to people who got it. And while we're talking about treatment, we need to talk about prevention. This slide just shows you the major causes of cancer in the United States. You can see down there, it's no surprise, 1/3 of all cancers are caused by smoking. And it is true that in a number of states like West Virginia and Missouri, 30% of people smoke cigarettes today. In California, it's 10%, at least 10% who smoke cigarettes. We can do better in terms of tobacco control. Then look at the number 2 cause of cancer. Almost 30% of all cancers in the United States are caused by obesity, poor nutrition, which in this instance is too many calories, and lack of physical activity. Think of it as a 3-legged stool. It's not just obesity. It's obesity, too many calories, and lack of physical activity. This, by the way, is the point where I have to say I'm talking about obesity and not the condition known as being overweight. I'm not allowed to talk about being overweight because of a conflict of interest. We have tremendous ability to decrease risk of cancer. We need to focus on all of these things. Smoking, we need to focus on diet, we need to focus on exercise. Many of the things that we've done over the last 50 years, like every family, it used to be in the 1950s, every family wanted a car. Now every family has 2 or 3 cars. We are exercising less. We are walking less. We need to focus on prevention. It'll help us with diabetes and cardiovascular disease as well as cancer. And then we need to focus on getting human beings the care, preventive and treatment, that every human being deserves. Please remember, if all Americans had the risk of cancer death of college-educated Americans, 148,000 Americans would not die a cancer death this year. And that's actually an underestimate of how many deaths we could prevent if we got everybody good prevention and we got everybody good treatment. And I thank you.